There we go. Great. So, very, very warm welcome to Janieke van Nugteren. She's a doctor and a specialist consultant anaesthetist working in the Department of Anaesthesia and Preoperative Medicine at Groote SchuurHospital in Cape Town. She's a full-time clinical anaesthetist and provides anesthesia for many subspecialties. She's developed a very special interest in chronic pain, and for the past 10 years has led the interdisciplinary team at Groote SchuurHospital's Chronic Pain Management Clinic. At this clinic, they manage a large patient load in our resource-constrained setting, which we all know, particularly in the government and state hospitals, is huge. The interdisciplinary team comprises representatives from anesthesia, psychology, psychiatry, and physiotherapy disciplines, and includes, prior to COVID, a recurring 6-week chronic pain management course for patients. Dr. Janieke, thank you very, very, very much for joining us. And thank you. I know that with COVID around, you're exceptionally busy, and we appreciate very, very much you taking time out of your schedule to assist and inform us today. Thank you, and very warm
Perfect. Thanks so much, Karen. So I'm going to start. So I'm screen sharing. Let me just see. Okay, great. Can everybody see that as a PowerPoint? So I've just done a brief overview of pain, because I think part of the problem is that many of us just jump straight into trying to treat it rather than assessing it. And I do have a disclaimer in that we don't routinely manage people who have dementia, and particularly advanced dementia. Obviously, there's an elderly cohort in our clinic. And I do understand that the geriatricians and neurologists, particularly in the States, are completely overwhelmed. So people to access good information and clinicians is very difficult. So in reading around, I'm meant to write this European exam in pain last year actually, and that was postponed. But one of the subgroups is the special groups in terms of pain are people who have comorbidities, and in particular the challenges of treating pain in the elderly. So I think one of the first things that I think we need to try and get clear in our heads when we try and understand pain is what types of pain do we get? Because if we don't know what types of pain we are treating, then the analgesia that we're using isn't going to be right. So in medicine, we talk about nociceptive pain. So please don't be freaked out by these complicated terms. But this is essentially just pain that happens as a result of tissue damage. Or even something like osteoarthritis would be an example of nociceptive pain. And the reason why it's called nociceptive pain is because we have these little receptors in our periphery which pick up the threat or the damage signal. And those are called nociceptors. So that's where the name nociceptor comes from, nociceptive pain. Then we talk about neuropathic pain. And neuropathic pain is when there's been damage to the peripheral or central nervous system. So a good example of that be somebody who's had herpes zoster or shingles. So that little nerve is being damaged by the virus that was sitting in that nerve, and now that causes pain. And the analgesics or the pain medicine that you use to treat neuropathic pain is different to what you would do for nociceptive pain. Then you get patients who have an inflammatory pain, which is actually a type of nociceptive pain, because in certain conditions like rheumatoid arthritis, people will still have ongoing inflammation and tissue damage. So actually it is a form of nociceptive pain, but we also know that rheumatoid and the autoimmune diseases require other types of medication to target the immune system. And then you get this strange group of of pain called central pain amplification syndromes. So that's where you get abnormal pain processing. And a good example of that would be something like fibromyalgia. So patients have pain, but they don't have tissue damage, which is a very difficult concept for most people to understand. But essentially, we think it's a problem with the nervous system. So whether it's a peripheral nervous system, the spine, or the brain, there's some form of upregulation. And then we class pain in terms of acute pain. So people often say acute pain like it means severe, but actually acute means short term or a pain lasting within the norms of tissue healing, so say 0 to 3 months. And then you go on to develop chronic pain. And we usually say that's a form of pain which has been around for more than 6 months to a year. It depends on which sort of books you talk about. And we tend to divide chronic pain into cancer and non-cancer pain, because those are a little bit different as well in terms of how we manage them. So I think when you're dealing with a relative who has dementia, and we'll talk about assessing it in a minute, in our heads, it's important to try and think, what type of pain are we dealing with? And to be honest, doctors are even quite bad at assessing it in many instances, particularly in the chronic pain field, because we don't really know how to interpret a lot of the information that gets given to us. Obviously, if somebody's arm's been broken, that's a form of acute nociceptive pain, that's easy. But it's in the more complicated patients, and particularly in the non-verbal patients, where it's difficult to actually assess. So what actually happens, and this is not just talking about patients with dementia, but in all patients, once you develop a chronic pain, so I like to think of this like, this is a very nice example, this little barcode. So normally in healthy people, we have a normal adaptive process. So as far as normal can be described, particularly in this current circumstance. But we try to regulate all our things within normal confines. Obviously, some people will have a little bit less or more of the one. So in other words, if you look at these little pictures at the bottom, so you have pain intensity or pain unpleasantness or your autonomic disturbance, so that's how hyper aroused you are, your appetite, your sex drive, your sleep disturbance, depression, anxiety. So in pain, most normal healthy people are able to adapt and control all of those things. But what happens in patients who develop chronic pain is that not only does the pain become a problem in that it's constant and not going away, but it affects all these things. And you can see it depends on different people, will have different responses. And this is why treatment of pain is so difficult, is because, like, if you look at this little graph on the right, like the little barcode, this patient's pain unpleasantness and his cognitive dysfunction, or the way he thinks, has been the most affected by the pain. This patient, number 2, has got the pain intensity is the worst, and his autonomic disturbance is the worst. So it's very difficult sometimes just to answer questions in a straightforward, particularly about patients, because you want to assess and see what are the implications or what is the impact on each individual patient. So I like to share this, and it's called the lucio pain model. Lucio was a psychologist where he showed the onion, the lucio pain model, the onion rings, or many people have different words for it. But you can see what happens in people. So we have nociception. In other words, our periphery gets activated through tissue damage, or not even. So eventually, when people develop chronic pain, they just develop pain, and that's because of the nervous system being upregulated. And once you've had long-standing pain, you start suffering. And that suffering will ultimately lead to pain behaviors. And pain behaviors are, in people who are cognitively sort of intact, are things like a patient will come into my office and they'll stand and rub their back because that relieves the pain. So it's activities around trying to modulate your pain. And pain behaviors are a sign that a patient is suffering. So not to confuse you, just again to see that if we're looking at these biological pain mechanisms, nociceptive, neuropathic, and then there's this option of nociplastic, which is that amplified pain syndrome. But all of these will give people pain. Okay, so what are common causes of pain in dementia? And that is the case for most elderly patients. So osteoarthritis, pressure sores, particularly if they're bedbound, infections, skin tears, leg ulcer dressings, stiffening of joints, constipation, and muscle rigidity, obviously also from not mobilizing a lot. And what's interesting in Alzheimer's is that, or any form of dementia, this is particularly an article on Alzheimer's, is that sensory pathways that's within the brain. So remembering when we experience a pain, we need a brain in order to be experiencing it. But these sensory pathways may get damaged. And this may result in people having an increase in pain tolerance or not. And obviously the problem is that patients can't communicate their pain. So that leads me to, how do we assess pain? And And the literature seems to suggest that if patients have a mini mental score of less than 18, so normal mini mental score is more than is 30. If it's less than 18, then we should really be using these pain scales or pain tools. Now, obviously, that's difficult. So it's difficult for all the, I think nurses find it's often quite tedious to work out, or to have to do and to look at, and you can maybe share your experience with having used them as well. But I think one of the ones that is quite easy to use, and to me, having looked at it, makes a lot of sense, and even the academic literature seems to support it, is the Abbey pain scale, not about Abbey Smith. Looking at, and so what it does is how to use the scale. So while observing the resident, score questions 1 to 6, and when the last pain relief, so the patient's name and the time and when the last pain relief was given. And then it looks at things like vocalization. So is the patient whimpering or groaning or crying? And then it scores it from absent to severe. A facial expression, which looking tense, frowning, grimacing, looking frightened. And that's a score from 0 to 3 again. Change in body language. So fidgeting, rocking, guarding, part of your body being withdrawn. And then behavioral changes, so increased confusion, refusing to eat, or an alteration in what their usual pattern is. And then physiological changes, so things like temperature or pulse or blood pressure, which are outside the normal limits. And then perspiring or flushing or looking very pale. I must say that physiological changes are, even in anesthetics, if patients in the recovery room don't have a high blood pressure and a high heart rate, we tend not to say, oh, they don't have pain because they don't have a high blood pressure or heart rate. The association between blood pressure and heart rate is very poor. So don't look at those as objective markers which you're trying to use. And then physical changes like skin tears or pressure areas or arthritis or contractures. And then you would score those. And then based on that number, you could then say, okay, this patient has no pain or has mild pain or moderate and severe. And then what type of pain is this? Is this acute? In other words, they've just injured themselves, or it's still a tissue that's busy healing? Or is this chronic? Like maybe this patient had chronic lower back pain prior to developing dementia. Or is this an acute exacerbation of a chronic problem? In other words, they have lower back pain and it's been quite well managed, but now suddenly they've got some new pain on top of that. And I think that's possibly quite difficult, but obviously you need to know the patient and be familiar with them in order to assess that. So I think just for yourself to think about all the things that will result in the outputs of pain. So obviously the patient's age and their sex and their comorbidity and their health status and all of that stuff, and what type of dementia subtype they have, their affective components. In other words, we know that patients who have depression and anxiety this is in patients who don't have dementia, but even you could almost extrapolate that to a degree, often more difficult to assess though, is that having depression and anxiety could contribute to chronic pain, and having chronic pain may lead or be a risk factor for developing depression and anxiety as well. And then obviously your cognitive levels of functioning, how good is the memory? How good is the executive function? Can they reason? And with, things like vigilance and attention to that. And obviously the social economic status has an impact. And then the patient factors like physically, how impaired are they? Are they unsteady on their feet? And then that will then result in the pain report or expression. And obviously in severe dementia, it's more difficult to try and decode. And the healthcare worker and the person who's assessing the person, it's also influenced by their age and their empathy and perception and knowledge and beliefs and the experience that they have and how much they find this situation distressing or burdensome even to them. And that then results ultimately in a pain judgment, like do we treat this or do we not? So I think just the last two slides, the two most, or the literature, like I said, I don't treat many dementia patients or people with dementia, but I do have a big elderly population in the clinic, and there's no doubt that the evidence and the side effect profile for non-pharmacological treatments is really quite good. and obviously more time consuming, but things like exercise, and that would depend on the level of functioning. Movement therapies like sitting in a rocking chair, massage, human touch, heat and relaxation therapies, and then just plain human interaction and presence, which is obviously a bit more difficult during our current situation in the world. Okay, then if we talk about pharmacological treatments, and I think that's also the other problem that I experience is that people get put on a whole lot of treatment that they don't actually know what class or what drug they are. So they're actually using drugs from the same classes or drugs that contain little bits of the other one, but there's no clear plan. So when I try and rationalize medication, I try to say, okay, well, this medication has got paracetamol and that one. Why don't we just stop this one and put it all together in one group rather than having different bits of different things? Because you'll find it's very difficult to actually rationalize and know what's going on. So paracetamol is still a very good, safe drug to be used in the elderly. And I think lots of people don't actually realize that the combinations, and South Africa has this big issue in that many of our combination drugs like betapane and miprodol and all of those actually have paracetamol in it already. So you're thinking you're giving something stronger, but actually you're giving a bit more of this plus this plus this. So I like to say, let's keep it simple and put patients just on plain paracetamol and give them adequate doses rather than underdosing. That's a very good, safe drug to still be using. And you can see that that would be indicated for mild to moderate pain. The issue with non-steroidals, so that's Brufen, that's Voltaren, is still a problem in the elderly. Not just because of things like gastrointestinal bleeding, but also can cause kidney damage if you use it over a long time, and can worsen things like high blood pressure and heart failure. So we tend to shy away from using them, particularly long term. There is some advantage, though, to using, there's two types of non-steroidal. So you get a COX-1 inhibitor and a COX-2. So COX-2 would be a drug like Celebrex or Ocoxia. Those are safer. So if you do have an issue with inflammation being a big problem, then using a drug like a COX-2 inhibitor is not a bad idea. The issue with using opioids is that in the elderly, and particularly in the demented patient, it can worsen confusion. It can lead to falls, and together with other drugs like your benzodiazepine, so those are all your PAMs, like your clonazepam, your alprazolam. If you use them in combination, then you have a risk of worsening confusion and cognitive issues. So there is one of the opioids which the literature seems to suggest might be something to consider is a drug called buprenorphine, which is like morphine but is much safer. And the nice thing is you can put a patch onto the patients. So that patch lasts for a week. It's very expensive though, that's the downside. But some patients, if you start them on a low dose, you might find that they might settle quite nicely on that. But there are other options prior to using that. And then in terms of your adjuvants, we use certain types of antidepressants for pain as well, and those drugs are called venlafaxine or duloxetine. I went to read a little around that, and there was a few randomized controlled trial. Well, there was one, particularly looking at venlafaxine, and it didn't seem to help much more than. So we think these types of antidepressants, they're called SNRIs rather than SSRIs, are better in pain, but the study seemed to not suggest that it was such a great idea. So we would use SNRIs for neuropathic pain in particular. So a patient who has a spinal cord injury or a thalamic stroke or herpes or shingles pain. And then there's a class of drugs called your gabapentinoids, and I'm sure many of you have heard of this class of drugs. So that's called pregabalin, or its trade name is Lyrica, and gabapentin. And what those drugs do is they are used for neuropathic pain as well. So they're actually indicated for patients who have got a diabetic painful neuropathy. So that's patients who develop a glove and stocking distribution of pain in their hands and their feet. And there's a lot of evidence for it really helping with that. And we would use it for somebody who has herpes zoster or shingles pain as well. And those drugs are actually quite a good group of drugs. So I think I've been asked a few questions. If we talk about patients having neuropathic pain, we need to treat them for neuropathic pain conditions. I've had a few questions about CBD oil in particular. I think if you look particularly at like the Canadian guidelines, it's important that you first try your standard neuropathic pain drugs before you leap into CBD, particularly with the issues of patients being on drugs that might interact with that. And yes, CBD is relatively safe, but the evidence for it isn't that great. And so I would rather argue, let's rather use drugs that are used for neuropathic pain, which are pregabalin and venlafaxine or duloxetine and amitriptyline. So those are the 3 drugs that the South African neuropathic pain guidelines recommend. The problem with amitriptyline is that can definitely worsen confusion and cognitive decline and things like urinary retention. So I would suggest not to use it. And in fact, we don't like to use it in people over 65, although many of our patients have been on amitriptyline for many, many years. But I would rather recommend changing it and using a drug like pregabalin and a low dose, rather than jumping straight to your cannabinoids, which in this setting in our country at the moment, I feel quite unregulated, and you don't really know what is in the drugs. Until it is proper evidence, it still makes sense to me in terms of following a normal pathway of care would revolve in your first and second and third line. And once you've failed all of those, then you would consider using CBD. So I hope I haven't confused you too much, but just to give you a bit of a broad outline, I thought we could now chat, and I'm happy to field some questions.
Thank you. Oh, Corin, you're on mute. Okay. Thank you so much, Janieke. That was incredibly informative. I was absolutely riveted, I'm sure, as with everybody else. So
I've never had someone say that about pain.
No, but I mean, it's so fascinating. And I think for so many people, I mean, I see who's kind of on with us today. I think so many people who are the primary carers for loved ones. It's so, you know, you've given kind of so much to go back and unpack a lot of that. We had a few questions come in off the email and the WhatsApp. Corin, do you have any of those on hand?
Yes, so the one is the causes of the mom's pain. I think this one was sent to you.
Was that from
Lynn?
From Lynn, yes. Yeah. So can I answer specifically about the case? I mean, is Lynn online? Then I can chat to her.
I think Lynn online. Yes, Lynn
is
online.
Lynn, I'm going to unmute you if that's okay. There you go.
Yes, go ahead. Thank you. I'd appreciate it. Thanks.
Sure. Hi, Lynn.
Hi.
So reading through your mum's, I don't know if I don't know if I maybe should give some information maybe for other people to, I mean, are you okay to share that, or I'm
sure.
just wondering. Okay, so Lynn's mum is 84, I believe. How verbal is she in terms of communicating her pain to you?
Very, yeah, she can quite adequately, yes.
Okay. And so you won't really need the scale in terms of assessing what pain she's able to tell you.
Yes, she is, yeah.
And what does she tell you about the pain?
Well, it seems to be almost like a chronic thing. So she will wake up with it, and obviously from sleeping, the stiffness sets in overnight. And then walking obviously is difficult. Even throughout the day, if she does walk a little bit, it continues to be painful. Her hip gets more painful, obviously, as she walks and stands on it. The arm stiffness she's experienced from a bad fall, the mobility and the use of her arm is very, very restricted as a result of the injury and the shoulder replacement. So I would almost say, and again, not quite understanding all the terminology, but to me, that's almost like her day-to-day, what I call her sort of chronic pain. And then she would go into occasionally having a very, very bad bout of sciatica, which is really very, very severe.
And does she describe that sciatica as a leg pain that's burning? Or how does she describe that to you?
It's a shooting pain that goes down the leg. So it starts on the base of the thumb and then go go down the leg, and she used to have it on one side, now it appears to be on the other side. And yeah, she says it's like a hot poker going through her leg. Yeah.
So that sounds very much to me. So like if we go back to our principles, we're thinking about nociceptive pain versus neuropathic pain. So the nociceptive is those stiffness and the pain related to her injuries, which she had from falls. And the basic treatment for nociceptive pain would be paracetamol. And I saw that you were giving her paracetamol, but you were giving her betapine and miprodol forte. Now, the problem with our combination drugs is that they have a little bit of paracetamol in all of them. And then I think it's the miprodol forte has got the ibuprofen in it. And that's the non-steroidal that I said can give problems. So I would rationalize things and make it a lot cheaper for you, because I know people have a lot of perception about things like the betapine being better. I mean, the betapine I think has the codeine in it. I always have to go look this up myself, to be honest. Because
that has codeine. Right.
Codeine in it. And she doesn't get side effects from the codeine.
Not that I'm aware of. What would a side effect be?
So constipation, yes. Which is, okay.
She does have that,
okay.
Yes. But with or without betapine even, yes.
Yeah, exactly. And that's obviously a problem in the elderly. So if she doesn't seem to become confused from the codeine, then I don't think it's a problem if she stays on that. But the dream combination for me would be to say 1 gram of paracetamol, so that's 2 500 milligram tablets, 3 times a day.
Okay.
So what you're doing by that is you're preventing the accelerator from accelerating. You're just keeping it idling rather than giving it PRN. There is controversy and difficulty with people saying, oh, we can't use paracetamol for too long because it's concerned around liver damage. I've been using it for many years chronically, and you really need to take a lot more than that. So we say you must take more than, if you take 4 grams. So at that time, she'll be taking 3 grams in a day. Like, it's safe. So 1 gram of paracetamol 3 times a day. We even up it to 4 times a day in the non-elderly. Then, so that would be for our nociceptive pain, but I'm worried that there is an element of that arthritis or inflammation. So another thing, rather to avoid, I don't know financially what the situation is, but Celebrex or Arcoxia is a type 2 or a COX-2 anti-inflammatory, which is better than Brufen, because remember which is the one that's got the Brufen in it, miprodol forte, I think. Because you see, they've also, a lot of those drugs have got, if you go actually look, they've got things like meprobamate and caffeine and a whole lot of other little thingies in them that you don't really need. And it just adds to the issue of confusion with polydrug and multidrug pharmacy in the elderly. So I would say 1 gram of paracetamol and then an anti-inflammatory for those days where things are really bad. And that I would suggest using Arcoxia or Celebrex at a dose of either 200 milligrams once a day of the Celebrex, or Arcoxia, you get 60, 90, and 120, but I would start on the 60. And that's just a once a day dose. So you've got this nice background of paracetamol, using an anti-inflammatory for those days that are really bad. And then I'm thinking for those times that she has that sciatic pain, which is what we call neuropathic pain or nerve pain, a better option would be to use low-dose Lyrica or pregabalin. And, and that I would use like 25 milligrams at night, because it can lead to confusion. It can lead in high doses, but also it settles. And I saw she was on quite a lot of the alprazolam and clonazepam as well.
Yes, yeah.
Is she okay with all of that? I mean,
she's very tired and quite lethargic. So I think that the Alzheimer's and what have you are causing
contributing.
A lot of, yes, you know, just sort of causing her to be quite flat in terms of tiredness. But I think also, as she says, she would rather sleep than be awake with the pain. So that's also, you know, one of her rationales there. But doctor, I'm just thinking she's currently on Zytomil, which is an antidepressant, and I know Lyrica is as well.
No, it's not an antidepressant.
Is it not an antidepressant?
No, it's not.
It was. Okay.
No, so it's called a gabapentinoid. So when they first discovered it, they thought it was related to inhibiting GABA, which is what your your benzodiazepines do, so your clonazepam and alprazolam. But they've subsequently completely refuted that. It blocks the calcium channel in the spinal cord that permits nerve transmission. Mm-hmm. So it's absolutely not an antidepressant, and it's very, very safe. And the nice thing, there's gabapentin and pregabalin. Pregabalin is a twice-a-day dose, but what I'm recommending to you is just giving her a night dose. She doesn't have kidney failure as far as you know, or anything else like that.
No, I think her kidneys, last check, were in good working condition.
Okay.
Yeah.
So, and who's prescribing the benzos for her? Is that...
It was her doctor, who you probably do know, Dr. Freeman. However, her clinic is closing. So that was prescribed. Also pre-existing meds. She had been on these meds for quite some time. And her doctor just sort of moderated some of them, adjusted, and, took her off a sleeping tablet and rather put her on Rivotril because of some of the manifestations of the dementia. Yeah.
Okay. Yeah. So I think, I suppose because I said I don't have that much experience with Alzheimer's, I was like initially thinking, okay, that's quite a lot of that. But if it's helping her, maybe by getting her pain better while using our simple analgesic paracetamol, Celebrex or Ocoxia, and then a nocte dose of Lyrica, you might be able to scale back on using the benzos, which might leave her maybe, being less flat and tired.
I think the gabapentin, is that the Lyrica that you mentioned?
That's, Lyrica. So there's gabapentin and there's pregabalin. So gabapentin's name is Neurontin and pregabalin is Lyrica. So go for the Lyrica, the song, Lyrica.
Okay. And would that be, is that just for her ongoing pain management, or would that be for the sciatica pain?
Yeah, so it depends on how much nerve pain she has related to other things. She's not a diabetic. No. So if she has the sciatic, like you said, that only happens every 4 to 6 weeks.
Yes.
I would then say rather use it only then when she has it. Because the joy of that treatment is it works quite quickly. It works within a day or two. Whereas I don't see the point in her being on it if she's not having those exacerbations. Then it just contributes to polypharmacy problems.
Yes. Well, the sciatica really is a matter of hours. So she could be fine in the morning. She could have just twisted somehow. And by afternoon, she's in extreme pain. And it would last probably for about 4 to 6 hours. And that's normally when I do give her an Elzam to help her sleep, because very often after sleeping, she wakes up and the pain has gone. And at that time, we would have given her the Mypaid Fort together with an Elzam. So I'm looking for what alternatively could we use instead of the Mypaid Fort.
So then I would use the Celebrex or the Ocoxia at that time.
For that specifically.
For that, so you would use that. So you would use it. So if you, on a day-to-day basis, seeing she needs, you would normally use a once-a-day Celebrex or Ocoxia. But during an exacerbation, I would say give her that plus 1 gram of paracetamol, the nearest one that she's due to have at that time of the exacerbation.
Okay.
You could then, I'm wondering, like you say, we don't necessarily have, you say it's a quick exacerbation. It doesn't last for like days on end.
No. It's less than half a day. Yeah.
Which makes me wonder, that's quite unusual for neuropathic pain to come and go. So often what it does is we say it's paroxysmal. It comes and goes. I would then maybe avoid using the pregabalin and rather just see if a COX-2 inhibitor works, just the Celebrex.
Just try that for as and when she has an acute attack.
Yes. Because in all likelihood it's an inflammation, and even if it's a neural inflammation, then that will work.
Okay, so then we will continue then with the 3 milligrams or 3 grams, I should say, of paracetamol.
Plain, and you don't have to buy the fancy stuff. Just buy a plain Panado. Yeah.
Okay, so that'll be like
2
a day-to-day management. Yeah.
Yes.
And then you mentioned there was something else. Sorry, you mentioned the Lyrica. Should that be an option, or is that being replaced by the Ocoxia? Your suggestion?
Yeah, so I would say if you are finding you needing to be giving you see, so they're still two different classes. So the alcoxia would be for nociceptive or inflammatory pain, and then the Lyrica would be for true nerve pain, which is ongoing. So an example would be shingles or the painful diabetic neuropathy in a diabetic, or trigeminal neuralgia.
Her ongoing pain is more shoulder pain and hip pain.
Okay. So, you know what? So actually, a lot of the orthopods will often phone me and say, I've got somebody who's got hip and shoulder pain and they don't qualify for an operation to have a hip replacement. Can I give Lyrica? And the reason why I give it in that instance is because when you have this ongoing joint inflammation, your nervous system gets upregulated and starts barraging the brain with messaging. So what Lyrica does in that instance is it doesn't take away the inflammation, it blocks the nerve signal to the brain. So I would say it's not unreasonable to try it. And then if I did, I would give her, I'd be reluctant to give it to her. So we normally give it twice a day. I would give it to her at night, like a 25 milligrams at night.
Okay.
So why don't you try the alcoxia and paracetamol? And if you're seeing that she's still, so you're using it once a day, alcoxia, together with your paracetamol. If you're then still seeing that you're still struggling, then I would say then add the pregabalin.
Okay, so alcoxia, the daily treatment would be the paracetamol plus one alcoxia,
Yes.
And then if there is still the what I call the acute, very severe pain, then consider the Lyrica, you said.
Yes. So paracetamol doesn't have side effects. Your alcoxia won't have side effects. The only thing that you'd be concerned about is pregabalin or the Lyrica, which might make her a little bit confused. But I mean, she is already taking quite a lot of benzos. So I prefer for her to be on the Lyrica side than the benzo side.
Benzos. Yes, that's what Dr. Freeman has mentioned all along.
Okay. We don't like benzos in the elderly. It just.
I know. However, for her, it's like her life.
I know. If it was me, give it to me.
Thank you for those suggestions.
Pleasure.
We consider it.
Pleasure.
Fantastic. Thank you so much.
That's great. Excellent. Dr. van Nugteren, the other question we have is about analgesics and pain and things causing constipation in the elderly. What is your suggestion? One of the questions is a patient that has been constipated, has been on a laxative for a few days, but has been constipated for 5 days. After 5 days was moaning, became very weak and became very pale, but constantly moaning. What does one do when it is a toss-up between constipation and pain medications? Can pain medications cause some kind of constipation? Yeah.
So that scenario could be somebody who is so constipated that it's become unpleasant. So obviously you're feeling uncomfortable if you haven't passed stool in 5 days. The most common drugs, and this is a problem if you Google any drugs, I always say constipation, but the biggest, the most guilty drugs are the opioids. So that's codeine, tramadol, and morphine and oxycodone, or all the opioids. So the people who make the oxycodone have made a formulation that's got naloxone in it, which is the reverser of that, to try and reduce the amount of constipation, but you still get it. So I would say if the person is on an opioid, then the first thing to do is maybe rationalize and try come off that, try think of other drugs that they could be using. And then if they really aren't passing stool, then, I mean, in our hospital, we would say to somebody they can get a fleet enema per os or per rectum if it's that bad. Wow. So to me, that looks to me like an autonomic situation where the patient is quite uncomfortable with that constipation. But, you know, there might be other things. But, I mean, 5 days of not passing stool probably could be a cause.
Okay. And then the other question is, in terms of crushing medications and trying to get the patient to have them through being crushed and on top of food or in food, etc. What are your thoughts on that? And then the other thing is that are there any liquid types of pain meds that can be given for those that do still have problems in
swallowing?
Yeah.
So crushing it is absolutely fine. In most cases, it's only long-acting formulations which might change. But like, capsules that you pull apart and they got those little granules, that's perfectly acceptable. And that's maybe a thing. So if something comes in a capsule, you can always just empty the powder onto or into a liquid. I would say, so buying a pestle and mortar to crush is absolutely fine. One of the few things that do come in a syrup solution is codeine. So, and mismorphine as well. So mismorphine or sulfate, which we use in cancer pain as well, that comes in a syrup formulation. Paracetamol, you could use the children's formulation, but the problem is you end up using quite a lot and it's quite sickly and disgusting. But it's not a bad idea. I might need to look into whether you get higher concentrations of paracetamol. But you could always look at the children's dosing, but you might end up developing diabetes from all that sugar in those berry flavors. But I think it's not unreasonable to ask a pharmacist. Pharmacists in the olden days used to make up their own drugs. And so you could always ask them, like, could you maybe help me? My relative or whoever is struggling to swallow, could you give me some advice as to what liquid formulations I could use or the equivalent thereof?
Right.
And then obviously there's patches as well. So topical non-steroidals like Voltaren patches are still great. I used to think they didn't really work, but there is some evidence that particularly someone who's got knee osteoarthritis, for example, who you're obviously not going to be doing a knee replacement on, putting a topical non-steroidal patch, so that's got something like Brufen or Voltaren, is a very good idea. Also because it limits that systemic absorption, which you would worry about. I mean, you do still get some systemic absorption in your body, but not a lot. So if you have a problem with your kidneys or you have a risk for a gastrointestinal bleed from an ulcer, then it's a very safe drug to still use. So topical things are something we shouldn't underestimate the value of either. I know UMS, the patient at the hospital call it rub. So that's UMS, urea methyl salicylic. So that's topical aspirin. And that's also totally acceptable to rub onto patients. So I think we must also, always be careful. Systemic drugs have so many side effects. I think peripheral and non-pharmacological as well.
Right. And where would those types of patches be placed on the body?
So if you have an area like Lynn, like your mum who's having shoulder, I would say put the patch on the shoulder, or if it's on the knee. So wherever, that's if you're using the non-steroidals. If you're using a patch like an opioid patch, which is like a buprenorphine patch, Savanor we call it, or fentanyl, those are like strong opioids, then those usually are put in the region of the upper limb. So then it just gets absorbed by the body. But if you're using a topical non-steroidal, then the place to put it would be on the actual joint where you need it to be working.
Right. Okay, that's great. Does anybody else have any other questions regarding that? Because we know that in people with dementia, living with dementia, it's always the decoding of the non-verbal, types of groaning or grimacing or facial expressions, or turning them, or so that you're able to really ascertain exactly where the pain is and if they do have pain. So I think that those things are really difficult. And, as caregivers, it's sometimes pain can be something that is sometimes really overwhelming. And I think that you've answered and you've certainly put in context the understanding of what pain is and how we can go about decoding a lot of that. So it's been very, very, very useful, and I must thank you very, very much, Dr.
I think the decoding part is probably even for myself to decode pain in verbal patient, in people who can explain their pain is even difficult. So I can't imagine how difficult it is. It's like, I suppose it's in little babies also, it's equivalent, trying to point out what is the problem here. It's very hard.
Yeah, and one usually has to go through, a number of things to see, is it maybe hunger, is it maybe dehydration, is it, whatever it is, to go through that, to understand that. And obviously, in the very, the sort of the last stages of the illness, it does become more of a problem because, churning is painful, they really are very thin. And so there's a lot of other sort of things that can happen, tears in skin, those types of things. So we really, really appreciate your.
May I ask a question?
Sure.
So as the group know, although I have not cared for somebody with dementia, I have cared for terminally ill parents and siblings. And I always remember the person who helped us with pain management would always say, it's easier to manage pain than it is to get out to deal with it. So kind of once you've gotten on top of the pain management, one really needs to, and you mentioned this kind of about the paracetamol when you were speaking to Lynn, but if maybe you could just touch on kind of once somebody's on some sort of pain management system that seems to be working, is that kind of the new normal? How does that work?
Yeah, I also vacillate myself. We used to say, keep the pain under control. Give your analgesic by the clock. Every 4 hours, give it. And I think if the side effects are not bad and you're finding, this patient is actually okay, then I would suggest advocating for that. We know 60 to 80% of patients living with dementia do have pain. So, the gamble is rather just give it if you don't have a major side effect profile, give it regularly. So I would advocate probably for that. So regular, by the clock, keeping it under control rather than having a situation where it's spiraled, like you say, and nothing you give is helping because it's exploded. The downside and the counter argument to that would be to say, well, I find they become tolerant of it and it's not working anymore. I would rather argue that you're keeping it at a base and then you could always use stronger stuff if you need to, rather than coming from nothing, having lots of pain and then really needing to escalate it. So if a drug like paracetamol is safe, then I would say give it 3 times a day, keep the engine idling as opposed to accelerating, and then giving those stronger things as needed. Almost like you would in cancer pain, treat like for breakthrough pain, you'd be able to then make inroads. You have a baseline and you would then give things for breakthrough.
Yeah. Thank you. And now no one wants to see those that they love in pain. So I think it is such a, it is such an important thing to kind of really be on top of. With regards to the document that you shared about the Abbey pain scale, would that be a document that kind of the group
yes,
would be value in sharing that if you?
Yeah, no, I'm happy. I mean, you can find it everywhere on the internet. It's not
I'll share that with everybody on our WhatsApp group because it seemed quite easy to understand and its answers can really be helpful.
Yeah, and then once you know what your score is, you can then just go say, okay, now where are we on the stepwise approach? Have we given our base? Do we increase it? Where do we go from there?
Yeah, I think that it is. It's important to have those kinds of tools available. If you do start seeing that your loved one is experiencing pain more often, so that you are evaluating it and you can actually tell the doctor or the specialist or so exactly what's happening in terms of pain and pain management. Because very often, I think that pain is overlooked as something which is an underlying thing. It's, maybe it is constipation, maybe it is dehydration or this or that. But pain is something that is not really, because it's not something that is verbalized that easily. So the other question that I have is, does somebody's pain threshold change as they get older?
Yeah, so it's...
So, for example, if you had a very high tolerance, yeah. Sorry, carry on.
Sorry, just say that last sentence again.
So if you had a high tolerance when you were younger, is that the case when you get older, or does your pain tolerance change as you get older?
Yeah, so there's not clear evidence on that. We do know that changes in your nervous system, so as you get older. So like I was saying, with Alzheimer's in particular, they know that the actual century, so remember you've got your peripheral nerve and you've got your spine and you've got your brain. And we talk about your brain as a pain matrix. So it looks at, this message comes into the brain, and based on your memory, your emotions, your current situation, we know that if you bump your elbow and you're having a bad day, that pain is far worse than when you've actually just won the lottery. So your current circumstances have got a lot to do with how you experience pain. And hence the reason why depression and anxiety may exacerbate pain, because serotonin and noradrenaline are two hormones which we have in our bodies that make us feel happy and less depressed. And we know that they go down in depression and anxiety, and they are also the same neuropeptides which help to fight pain. So if you have that depression and anxiety and you have pain, your pain experience is going to be far worse, because you have a message coming up to the brain, and then your brain also sends down a message to the spinal cord to block that incoming message, depending on how important the brain thinks that message is. If your downward pathway becomes deficient, which it does in depression and anxiety, your ability to block those messages becomes less and less and less. So in other words, your pain threshold becomes less and you're experiencing more pain. But the problem with pain thresholds is that it's a very subjective thing. Yes, you can test it in a laboratory, like you could say, okay, I'm going to put your arm on a plate and you're going to tell me when you can't stand it anymore. And that is obviously our innate threshold. But in terms of the elderly, what's interesting is I think the burden of disease in the elderly is more. You know, people have osteoarthritis, people have spine, disease of the spine that can contribute. I don't think if you're a healthy elderly person whose ability to deal with stress and stuff, then your threshold should remain the same. It's when you start getting other things like stroke and depression and anxiety and stuff that your ability to manage it becomes less. Right. Interestingly, if you look at persistent post-surgical pain, it's actually younger women in their 40s to 50s who are more at risk of developing it and having a history of depression and anxiety that are at risk. So it's not really, I can't really say that old people have lower pain thresholds, because it's so inter-individual based on so many different things.
Amazing. So I'm going to ask Abigail to thank you so much, but from me, an enormous thank you, and from DementiaSA, but I know Abigail will end off the session for us. Thank you.
So thank you so much.